presentation, and we are very honored that among us we have the BIHS lead, Professor Dr. Fazlur Rahman sir, who is the DG of BIHS General Hospital, and also the international lead, our Honorable Dr. Amin Islam sir, who is the Senior Consultant Hematologist from the Mid and South Essex University College London. And among our audience, we have Dr. Rumana Rashid Madam, Consultant Hematologist, Barnsley Sheffield Teaching Hospital, and also Dr. Natalie Oden, who is the Senior Transfusion Practitioner of MSc University Hospital, NHS Foundation Trust, and also many other experts in this field. Today we will have two presentations. The first presentation will be from Sir Solimullah Medical College and Mitford Hospital, which will be presented by Dr. Mohammad Kamruজ্জামান sir, who is the Associate Professor and Head of the Department of Hematology in that hospital. And the second case will be presented from BIHS General Hospital. The team of speakers is headed by Dr. Mohammad Shahidul Islam Shingda Rumi and also some other presenters here. Now, with the permission of the chair, may I request our first presenter, Dr. Mohammad Kamruজ্জামান sir, to start the presentation, please.
Thank you. Am I audible?
Yes. Yes.
Okay. Honorable Chairperson and distinguished guest, panel of experts, Assalamu alaikum and good afternoon. I, Dr. Mohammad Kamruজ্জামান, going to present my a typical case. All of you seen the my slide screen?
Yes. But can you, sir, please go to the slideshow view, sir? Full screen view,
Yes,
sir.
yes. Okay.
Yes.
A young male presented with fever and bleeding. Mr. Sunny, 18 years, male, non-alcoholic, non-smoker, non-hypertensive, non-diabetic, hailing from Trishal, Mymensingh. On December 2023, he was presented to a hematologist with the complaints of fever, gum bleeding, multiple purpose spot, and right subconjunctival hemorrhage for 2 weeks. On examination, he had no lymphadenopathy but mild hepatosplenomegaly. CBC revealed hemoglobin 7.1, WBC count 7,800, and platelet count 24,000. Peripheral blood film shows acute promyelocytic leukemia. Bone marrow study also reveals acute promyelocytic leukemia. This is the slide of peripheral blood film. This is the promyelocyte. This is the bone marrow slide and seen the promyelocyte. As she was highly suggestive of APL, all-trans retinoic acid was started immediately and blood sample for RT-PCR of PML-RARA gene was sent, but result was negative. He was referred to National Institute of Cancer Research Hospital, Dhaka, and again bone marrow study and immunophenotyping for acute leukemia was done, and reports revealed acute myeloblastic leukemia, and flow cytometry revealed positive for CD30, 33, 170 MPO, and 34 team HLA-DR team. He had came to the Department of Hematology, Sir Solimullah Medical College, Mitford Hospital for treatment purpose. We took history examination, the patient thoroughly, and review the peripheral blood film and previous bone marrow slide. We found typical promyelocyte with horrors. His coagulation profile was normal, despite extensive bleeding manifestation, he also developed non-healing scrotal ulcer during hospital admission. ML cytogenetic study done, but no cytogenetic abnormality detected. We continued all trans-retinoic acid and sent blood sample for new generation sequencing. After 1 month later, NGS report revealed clinically relevant pathogenic mutation identified in WT1 gene, but no other fusion identified. This is the NGS report. And we did bone marrow aspiration day 72 of all trans-retinoic acid, and it reveals APL in partial remission. That is 10 to 15% of promyelocyte. This is the bone marrow slide. Karyotyping normal. We did FISH for acute leukemia panel.
Yeah, নতুন AP live member হইছো মেমে
হয় নাই তো
Okay. PML RARA fusions signal was detected in 3% cells only, but sample was negative for translocation 15-17. GATA2 and MECOM fusion signal was detected in 10% cell, so the sample is positive for GATA2 MECOM. Last CBC shows hemoglobin 14.4, total count 5,420, and platelet count normal. Bone marrow study shows APL in partial remission. My query or my the aim of presentation is what will be the further treatment plan, what will be the consolidation protocol for this patient, or this patient is APL or we treated with non-APL or ML like that. Thank you, sir.
Interesting, Kamrujaman. As we had some communication and I have reviewed the case and we made some recommendation. Professor Mahesh from Cambridge and Ipswich, do you mind commenting on the case? Mahesh?
Yeah, hello, hi. So just to summarize, so AML standard risk with no cytogenetic abnormality, but the NGS found BCOM. Which rearrangement was it seen? GATA mutation on a young 24-year-old. Is that the summary?
Yes.
Okay, okay. So you could go for standard risk of
WT1 mutation in NGS and FISH showed GATA MECOM.
GATA MECOM, okay. Okay, so in the standard risk, it will be a standard risk AML, isn't it? From looking at it, but the NGS, I'm not sure about where the GATA comes in terms of the stratification. But standard of treatment will be DAR to start off with. But you could always say that you could add Mylotarg because he's a standard risk. And then what is the NPM and FLIC3 status? Because we make some changes on the FLIC3 and NPM status. So that I assume that is negative. So we go for injection with DAR plus or minus Mylotarg, and then and you don't think that he need to be remission after first cycle to see what exactly is happening after that.
Yeah, fascinating. Thank you, Mahesh. I think looking at the case in details, it appears to me that this patient has got cryptic translocation of APML RARA gene mutation. There is an escape WT1, as you see as well. And some percentage of the PML RARA was positive. You said 3%, Dr. Kamrujaman. And the beauty is your patient responded so well with ATRA, and you added on arsenic trioxide, and patient is in remission. So it is very likely to be a cryptic translocation of APML, which is about 2 to 5% we do see. And this is where the NGS sits, you see, is very informative. and interesting to see these cases. In the past, we used to miss lots of these cases. As you know, AML is still cure rates is 50-50, including if you do the allogenic stem cell transplantation. But APML, about 97%, you cure them. Even with cryptic translocation, the cure rate is similar. And it is so important to diagnose this case, a cryptic translocation of the APML. And you have demonstrated this beautifully here. And that gives the chance of this patient being cured well above 90%, I believe. I hope that we will have Marian Grantham. I think she's joining in about 2 minutes. She's our NGS and molecular lab head of the department. Is Marian connected? We can go back to the case, I think, when Marian comes and you can show her the cytogenetics which you have performed. But apart from this, your question is, what is the consolidation? You should be following what you following the UK AML 17 protocol, which is ATRA and arsenic trioxide as consolidation therapy. I'll be very happy for you to continue the protocol, total duration of the treatment, and obviously MRD monitoring, as well as the PML RARA checking intermittently as part of the AML UK 17. Any comments from Dr. Rumana Rashid?
তোমার নিচে দেখো তো রোগী না থাকলে বেরোয় যাব।
Okay.
Hello, nothing to add. Nothing to add. Amin, thanks very much.
The important thing here is to remember, I was asked in Dhaka by Professor Akhil Ranjan Bishwas from Dhaka Medical College that he had a similar young patient with APML. A patient had a normal clotting test, but yet the patient was bleeding from everywhere. And your patient, similarly, PTAPTT INR is similar normal, but yet your patient is bleeding. What is the mechanism? Has anyone has any comment on this? We know that APML, about 70% patients has DIC and they bleed, but about 30% patient, their clotting profile is normal, but they still bleed.
So platelet count only 24,000.
Yeah. So the platelet, you see, time after time, we've been talking about this. Platelet is one of the very small component how we form the. We need factors. We need fibrinogen, as you know. No fibrinogen, no clot. You generate thrombin by giving all the factors, but if you do not have fibrinogen, you do not activate the clotting cascade. And what happens is if your fibrinogen, in a PML patient, you need to keep your platelets above 50 by giving multiple transfusion. And also you need to give cryoprecipitate or fibrinogen concentrate if available to keep the fibrinogen greater than 3.5, but 2.5 is also okay in our parts of the world because of the availability and the cost of this concentrate. What happens in APML, we have a trainee doing a PhD in UCL. He's trying to understand what is the mechanism of normal PTA-PTT INR in patient who has APML and why they bleed. You know, the factor 13 deficiency can cause the similar pictures. Whether there is a problem on the fibrin clot formation and the meshwork, it's yet to be identified. And I think this is PhD will probably reveal this in front of us.
Sir, I am Dr. Ashikuজ্জামান, hematologist. I am working in Sar Salimullah Medical College, working as assistant registrar of hematology. And from very beginning of the patient, I am with this patient. What is your question was why PTA-PTT is normal but bleeding? It is also written in all the textbook also. The promyelocyte, when abnormal promyelocyte can release annexin V1, and it is you know that it can break down fibrinogen and protein C proteinase also. And when fibrinogen is broken down, fibrinogen is less. All the pathway, extrinsic, intrinsic, and common pathway, till now it is not so much abnormal. But final pathway, fibrinogen, is abnormal. So there may be clotting without producing any coagulation changes. And this is I have also worked in Dhaka Medical around 12 years. So but we have seen many APL cases at first without there was no coagulation abnormality, but most of them, they were very much bleeding. But sir, here I have one question. The morphology revealed last bone marrow. I have given the report, and it was like promyelocyte. I agree. A cryptic translocation, that is a very good logic. We have seen Numarara, Stat 5B Rara, and everything, every cryptic translocation they have checked with this NGS and FISH, but all revealed WT on, and later on we have found in GATA2 Mekong. So can it be AML? Because AML blast can also be also release procoagulant. It can also sometimes present with bleeding. So as flow cytometry suggesting is acute myeloid leukemia, can it be AML? And we know in acute myeloid leukemia also, one of my experiences when Professor Salma Afroz Madam in Dhaka Medical College, we gave one AML cases that was morphologically almost like APL, and Madam that time was all investigations are not so much available. So she said, please start Vesanoid and ATO. We started Vesanoid and ATO. It was also went in remission. And there are many publications you can see. All-trans retinoic acid can give good remission to acute myeloid leukemia, but it doesn't have the curative.
Yeah, I think Professor Dr. Zaman is muted, I think. Marian. Kamrujaman, can you show the cytogenetics, the slides to Marian and see whether she has anything to add? Marian, we have a case and we believe possibly a cryptic translocation or atypical translocation of APML responded very well with ATRA and arsenic trioxide in remission at the moment. So I'm showing you the slides now.
So this is the NGS report.
Yes, can you click and open it? Yeah.
Yes, go to the bottom, click to open the slide. This slide is not.
No, I think you can go to your presentation.
Presentation. Okay, sir.
Presentation and go to the slide. Yeah, the cytogenetics and NGS slide.
Okay, sir.
Thank you.
Mr. Sunny, 18 years male, non-alcoholic, non-smoker, non-hypertensive,
Marian,
non-diabetic.
can you see? I can't see the slides.
On December 2000.
You can show the only cytogenetic report or NGS report, I think.
Cytogenetics reports not showed here. Yeah.
It's not open, I think. If you open the slide like you did, then yeah, thank you.
Only NGS and bone marrow slide. This is FISH report.
So we cannot see your slides, sir. Your screen is not visible here.
Marian, you have the case, and if you could have a look at the cytogenetic fish, and if you comment later on, and we can have a discussion, I think, afterwards about the bleeding manifestation in APML cases with a dysfunctional fibrinogen and using the normal PT and APTT a bit later. I think if we can now go to second case, I think Dr. Shahidul Islam Shikdar Rumi from BIHS.
So one thing can I add to audience? Can our plan be DA3+7 followed by HIDAC in this case? Um, Amin sir,
If you give me opportunity, can I start our case?
Yes, yes. And if possible, then somebody, Nafisa can mute everybody else apart from Shahidul Islam Shikhar Rumi.
Yes. Thank you for giving me the opportunity. I am also grateful to all of the participants connected from home and abroad. Today, you can see in the flyer. Today, you can see in the flyer that 5 presenters. Actually, due to time constraint, on behalf of them, with your permission, I am presenting the case, today's case. Can you see my presentation? Okay, thank you. So my case, 28 years old, male, married, service holder, presented to hematology OPD about 1.5 months ago with the features of weakness and history of 5 days fever suffered 1 month ago. It was suspected as a case of dengue fever, but evidence was not available. And recent incidental findings of pancytopenia during his regular follow-up. CBC revealed hemoglobin 9.4 and WBC only 800 per cubic millimeter and platelet 80,000. In that report, there was no atypical cell, but the lymphocyte was relatively high, 72%. At that time, there was no lymphadenopathy, organomegaly, bony tenderness, active bleeding, or any neurological findings. Performance status was according to ECOG 3. So we advised him for hospital admission, but refused due to financial constraint. After then, we advised for neutropenic precaution and GCSF for 3 days along with other supportive treatment. And 3 days later, CBC with hematology OPD follow-up. We gave GCSF considering that if there is a bone marrow suppression for viral illness, it will help. Or if there is any other disease, then we can follow in the next follow-up. So when patient came 3 days later after GCSF treatment, you can see the CBC picture. Now hemoglobin 8.5, WBC count 74,500, which was only 800. And the atypical cell percentage was 75%, platelet at now 10,000 only. Other tests are revealed, CRP was high, 160, LDS, renal function, liver function, echocardiogram, ECG was normal at that time. So we admit the patient and collected sample from the peripheral blood for immunophenotyping, cytogenetics, and karyotyping as well, as there is a high count and significant number of atypical cells in the peripheral blood. So this is the CBC picture after receiving 3 days GCSF. You can see a high cell count with significant number of atypical cells. So what immunophenotyping revealed, there was a 95% blast in their evaluation, and they revealed it's a case of AML. Positive marker CD13, 100% bright positive, 33, 100% bright positive, 117, 55% deemed positive, 64, 40% deemed positive, MPO 100% moderate positive, CD45, 100% moderate positive, CD34, 70% deemed positive. But HLA-DR was negative. Though immunophenotype revealed this is a case of AML, but in the CBC, there is a significant number of cells more consistent with acute promyelocytic leukemia. Then we communicate with them. They mentioned CD34 positive and HLA-DR, though HLA-DR negative, less likely to be APL. We know that HLA-DR may be negative in 10 to 20% cases in case of AML. So this is the significant cell we found in CBC, which may be a case of APL in our primary suspicion. So at that time, cytogenetic and karyotyping report was not available. those samples sent, and they mentioned you will get this report 2 weeks later. Then, considering all issue, we have to decide that this is a case of AML, as patient cell count was high and clinical condition was not good. So we have to start treatment for AML. And you know that the standard treatment protocol DA3+7, which we give. Here, for our hospital especially, we are highlighting the donorubicin dose, 90 milligram. It's a high dose. Cytarabine 150 milligram, and it will deliver 24 hours continuous infusion from day 1 to day 7. For this hospital, this is a new chemotherapy and this is a new treatment option. So I will discuss later elaborately regarding this issue. So before giving treatment, we counsel all the events, our limitation, our facilities, alternative option, other better option, so that patient can take decision independently. There was no biasness. But later on, patient decided to receive treatment from our hospital, and we started donorubicin and cytarabine-based treatment. So we took permission before giving this picture from the patient. He allowed. So you are observing that infusion pump, syringe pump, through which patient receiving chemotherapy. This is not usual phenomena for our country. Most of the low resource hospital, normal hospital, they have no facility for this kind of patient. But from the very beginning, first day of our hematology service, from this hospital, we are providing this instrument for chemotherapy and other treatment options. So many clinical events during this period, you can see fever, neutropenia, neutropenic fever, hypotension, all are usual consequences if you want to treat this kind of leukemic patient. And fever was very much complicated. First fever came day 4, later on it reappeared on day 6, and total 4 days fever. Sometimes 3 times, 4 times, 5 times paracetamol needed for this kind of patient. All the time blood cancer was negative. One urine CS revealed E. coli positive and cholesterol sensitive. We treated the patient accordingly. Gastroenteritis patient faced so many electrolyte imbalance, hypomagnesemia, hypokalemia, hypocalcemia, all managed according to protocol efficiently. Low albumin. Different types of antibiotic you can see according to protocol or local policy we used. And we also use antifungal. Just as quickly. Another clinical events, mucositis, visual impairment. So this patient developed pre-retinal hemorrhage and Roth spot. We consulted with the ophthalmologist, and treatment given according to his opinion. He can take some. He can give some opinion regarding the further management. Another issue, there is a single episode of cannula displacement. After then, there was an extra extravasation, small amount of cytarabine, localization, and managed successfully. Patient suffered from anemia, received 7-unit RCC, thrombocytopenia. We managed this patient with the platelet concentrate, 24 units, but this was random. In our hospital, apheretic not available. This patient also suffered from DIC, low fibrinogen. It was initially 59, high D-dimer, managed with 12-unit cryoprecipitated and 2-unit FFP. So you can see the picture of eye. It was taken actually after discharge. Before discharge, picture was not available, observed by the ophthalmoscope only. You can see the picture 2 days after the extravasation, right hand, and before the discharge, after successful treatment. So CBC change, you can see when we observe this patient in OPD, total count was only 800. After DCSF, it was 74,500. And day 1, after giving day 1 of DA3+7, it was at that time WBC count 4,700. So subsequently, day 13, patient developed nadir, and after then, patient recovered. On day 17, we observed that WBC count 1,000, but there was few atypical cell in the peripheral blood. So our assumption was most probably this is a refractory case. I would like to mention before starting DA and day 14 bone marrow was omitted or escaped due to the patient refusal and as well as financial issue. But at that time, cytogenetic report came and it revealed this is a case of PML RARA positive, that is acute promyelocytic leukemia. Later on, we planned for a trial ATO-based therapy for this patient. So throughout the treatment period, we observed ECG, we observed potassium, magnesium. You know that this electrolyte and ECG change usual with the treatment of ATRA and ATO. Patient developed ATRA syndrome, managed successfully with the IV dexamethasone. There was a swelling of both lower limb, and duplex study revealed there is a soft thrombus. But at that time, we want to start anticoagulation, but ophthalmologist refused that if you start and patient start to bleeding from eye, he may lose his vision. So considering risk benefit, we omitted this issue, but later on swelling and other clinical issue improved. Patient also developed skin rash, suspected Sweat syndrome, gradually improved with the treatment. So after successful treatment with ATRA-ATO, day 14, clinically totally stable, fibrinogen now 429, potassium always 4+, we try to keep it 4 up. And the CBC hemoglobin 8.9, WBC 3000, platelet count 210,000, and occasional atypical looking cells. So at that time, we discharged the patient and no further blood component was required after that. So this is the, in short, our clinical case. Now, actually, what achievement we actually gained from this case? The first point, independent protocol-based management of acute promyelocytic leukemia. This is the first time history of BARDAS, BARDEM, and BIHS General Hospital since its establishment. For time constraint, I just shortly mentioned whole scenario, but this patient admitted in this hospital around 33 days. So you can imagine we observe and we manage this case in this hospital. And whole team members of BIHS observe and experience the stringent management of hematological disorder. And this is the beauty of hematology. So sometimes fever, DIC, so many issues, but they observe this issue for the first time by this case. And successful incorporation of all relevant sectors without compromising patient care. You already observed that those other things we did not compromise. We incorporate nutritionists for neutropenic diet. We incorporated sisters, doctors, all the relevant sectors we incorporated. And you already observed that they are the real fighter. And initially, our challenges was new person for every new day. And we discussed many things, and we enjoyed that we can show the beauty of hematology with all of them, and they successfully ultimately gave treatment and patient improved. Capacity building and development of transfusion medicine department. We joined here 1st January 2022, and at that time only facility for whole blood transfusion. May 2022, we developed the transfusion service, RCC, platelet, concentrate, and FFP, cryo, all made available at that time. And August 2022, transfusion medicine full-time consultant joined. After then, it became more stronger. And overall scenario actually satisfied the patient. One thing I would like to mention that after discharge, before the Eid occasion, patient came to me with some gifts. And from my personal life, I always refuse to take some initiative, incentive, or other gift from the patient. This is my personal behavior. But at that time, when I refused to take some gift, patient became cry. So for his emotional purpose, I received some gifts. But I mentioned that you are giving me, but actually this is not for myself. Whole hospital, from administration, nursing team, doctors team, other relevant staffs, they actually gave treatment to you and you're satisfied. So this is not my achievement. This is the achievement for whole hospital. I am very much grateful and thankful to our Azad sir, DG sir, that we personally cannot give this kind of facility. Whole team, they created facilities and now we are giving this kind of treatment for this patient. So the message and appeal to all that inadequate facilities for patients suffering from blood disease and blood cancer in relation to huge need of our country. And this hospital already started to establish a plan to establish a cancer center. And before establishing this cancer center, with the existing facility, we can treat many patients. And we believe BARDAS, BARD, and BIHS are accountable for that purpose. As of today, hematology team, BIHS hospital showed their optimum devotion, dedication, potentiality to serve that purpose actually. Now our appeal, affordable, integrated, more organized planning needed to make it sustainable and long-term effective. So this is the appeal and message to all. Now we are sharing two pictures. They are the real fighters, nursing staff, resident doctors with the smiling patient. And this is the picture at the time of discharge. So thank you all for patient hearing. Now this field is open for interactive discussion, constructive criticism, or any other opinion regarding our management, our case, our treatment. Thank you.
Yeah. Dr. Rumi, you have demonstrated a very interesting case and outcomes. And as you rightfully said, that we are so grateful to the BARDAS Authority and the BARDAM and BIHS to realize the need of such entity, establish this entity within the BARDAS and the BARDAM and the BIHS. As you know, the hematology is the forerunner of cancer medicine. It started with imatinib about 3 decades ago, and now we have 180 tyrosine kinase and BTKI available for almost most of the cancer. So hematologist and hematology field is showing how the cancer can be treated, and now we have CAR T-cell, bispecific, and so on. And that will be translated to the other cancer medicine, and people will be benefited from it. And the BIHS authority has created the facilities, and we congratulate them. And the most complicated cases you have managed within your facilities, which is fascinating, with a very high cure rate. And you have shown that a DIC patient is the bleeding patient with retinal bleed as well, and also a patient who had thrombosis, and he is still alive and walking out from your neutropenic zone. It's a fascinating case and hard work. It's beautiful. It's beautiful. Now, Marian, do you have any comment on the first case about do you think it's a cryptic translocation? The assistant registrar from the Dhaka Medical College has highlighted that we can have our rods in certain types of the AML, as we all know. And ATO is very active treatment. Thousands of years ago, arsenic dioxide has been used by Chinese to use leukemia, and they had some success. And now we have arsenic trioxide and ATRA in it with AML UK 17 protocol, and the cure rate is about 97%. Do you believe the first case can be a cryptic translocation of APML rather than just a standard AML?
So I looked at the PowerPoint that you sent, Amin. I couldn't see the results to see what was said, but we know that in our experience, at least 5% of APMLs have a cryptic translocation by FISH and cytogenetics, and we have to use sequencing techniques to demonstrate the fusion. So if the cytogenetics was normal in this case, it could still be APML. Then you've got the possibility of a variant translocation involving another chromosome with RARA rather than PML, so that would need to be excluded. And just the other thing to say, without knowing all the full details, is we know that NPM1 mutated AML can mimic APML quite a lot, and we often get referrals for APML that are shown to be NPM1 mutated instead. So if you can't demonstrate the presence of a PML-RARA, it is also worth following up looking for NPM1 because they can look very similar and they can present in a very similar way with a very high count, and morphologically they can look quite similar.
Kamrujaman, you have done NPM1, H21,
Sir,
etc.
NPM1 negative, FLT3 negative, all negative.
Oh, negative. And so from the perspective of PML-RARA, you've had FISH and cytogenetics and both are negative?
Cytogenetics negative.
What about FISH?
FISH only GATA, MECOM. GATA, MECOM positive.
Oh, okay, so no PML-RARA FISH.
No, PML-RARA negative.
Yeah, so the Kamrujaman, you mentioned somewhere on the slide, there's a 3% of the cell were PML-RARA positive. What?
Yes, sir.
Yes.
Perfect.
So, Marianne, WT1 and the PML-RARA 3% positive. Does it tell anything? I use.
This is the NGS report.
Okay.
NGS shows only WT1 gene mutated. No other fusion identified, but FISH shows.
Yeah.
FISH shows only PML-RARA fusion signal detected in 3% cell.
Yeah.
But sample is negative for translocation 15, 17.
Is Marianne, the translocation is somewhere else giving rise to 3% PML-RARA? That's the question I think I'm asking.
Is this, did I understand correctly that this report is following treatment?
Baseline, I think initially the
Baseline.
was
Yes.
it post-treatment or
Post-treatment.
post-treatment? So yeah.
Patient getting ETRA
Already
on
received
that time. Yes.
And this is peripheral blood?
Peripheral blood.
Yes. So is it giving the less PML-RARA fusion gene? Or I don't know. I think the question is whether we switch to DA myelotag type of treatment, or we're happy with the ARTRA and arsenic trioxide protocol, AML 17, APML.
But Marianne, if you've got a fusion signal there in 3, would that indicate? Okay.
Why do you have 3% cells has got PML-RARA positive? Do you see it in other standard AML, non-APL?
No.
No.
But then not being it's quite small. It could be just background noise. It depends how they report and whether they include it would be nice to read the report.
Yeah.
Like,
I think
if you could email me a copy of the actual report.
Yeah, I think the actual report, if you, Kamrujaman, send to me and Marianne, then we can have a look. But for the time, as the patient is responding on the ATU and ARTRA, I think we're happy for you to continue, and then we make a decision. Fascinating, yeah. Both of the case, you know, this APML, the translocation detected in 1947, I think, by the Barnard, is one of the first mutation in human cancer genetics been identified. And now we have hundreds of the mutation detected, and we developing the targeted treatment. The one protocol fits all is a past at the moment. So the future of the cancer medicine will be so targeted, curative, but less side effects. That's the whole intention of treating a cancer patient, avoiding the collateral damage, treat what is the switcher. So you stop the switch and everything else is normal. Amazing. Yeah.
I mean, can I just say, so if this is a post-treatment sample, yeah, I mean, is there any material left from the presentation sample that we can go back and look at to see what the NGS showed on the pre-treatment sample?
Yeah, I'm pretty sure if, Jaman, if you have the diagnostic sample in some lab, either in the country or internationally, we can run the sample and see what was the original.
NGS from India,
Was
fish
it,
also from India.
yeah. And it was the diagnostic sample pre-treatment, right?
No, sir. NGS sample sent after 1 month of ATRA.
So that's why you see, Marian, I'm just thinking the ATRA, as you know, is a differentiation will stop. You will not have, you see, 100% the PML RARA fusion. So it's probably treated, partially treated APML and responded so well. And yet you have 3% positivity after 1 month of ATRA. So I don't see any problem calling it APML.
Yeah, I guess it's the presence of the GATA2 MECOM that's at 10%, which is unusual. But if that's by fish, that probe is quite challenging. It could be a misinterpretation of what the fish is doing.
Okay.
It would be, yeah, let's look at those reports.
Yeah, okay. Yeah, we're happy to send and then you can comment on it.
Okay.
Dr. Rumi, so what was your decision? What was the decision you didn't give anticoagulation in a patient who has APML and a proximal DVT? We know why you did it. It's brilliant. It's absolutely fine. But for the audience, when we see and the expert a DVT, we jump and we treat. But what was your justification not to treat? As we know, untreated DVT, 1/3 will end up pulmonary embolism and 1/3 patient will die at home. They will never see the hospital, see, because it's very dangerous. But you have taken the chance and not treated DVT because of the high bleeding risk. So bleeding risk and clotting risk. I think you are muted. Rumi, you are muted.
We have to consider the exact guideline as well as the local emotion. These two things we have to check and balance. So one thing, patient DIC already recovered after giving cryo, but patient having thrombocytopenia and target level was 50,000, but we could not reach at that level. Repeated transfusion 20,000, 30,000. So there is a chance of bleeding. Already patient manifested with the Rothschild retinal hemorrhage. So if we start and there is a further bleeding and if the patient lost vision, it will, I think, block all the consequences for ourselves. Another thing, just carefully monitor the limb, other clinical feature and duplex study-based therapy, whether it's propagating or progressive. So later on, swelling subsided, no deterioration, clinical and biochemical improvement. So we did not start this anticoagulation. But now, 1 week ago, platelet count is stable. And after consultation with the ophthalmologist, we started the rivaroxaban for this patient. And our plan to continue at least 3 months, then we will reassess our condition.
Amazing, absolutely. So this is a provoked DVT and you have taken a very careful strategy here. And again, thank you for that brilliantly. We do see problem in the Western world treating a patient with APML who has an active DVT or PE. It's very challenging and you managed it so well. We have to inform the patient about the informed bleeding risk and clotting risk. You might still bleed or you have clot, and patient has to be well informed on this, and careful monitoring. You obviously monitor the patient very, very well, and now started rivaroxaban, which is absolutely fine. And 3 months anticoagulation should be sufficient in a provoked deep vein thrombosis. Any other question, comment, Mahesh?
Thanks. We had a similar situation with APML with the DVT. I think you did the right thing. We may have not done the right thing at that time. So we didn't anticoagulate like what you did because he was having bleeding manifestations. But the challenge that came up is because we carried on with arsenic and etra, and they can get profoundly cytopenic. Didn't put on Roxban, we put on Clexane. And as soon as the platelet count goes less than 50, then we switched to, we didn't give it. From our experience, we had access to the IVC filter. So we put the IVC filter in, a retrieval one. I'm not quite sure whether we would take that one out, but at that time was very challenging because he was bleeding. He was having, even the access to IVC filter, he was bleeding there as well, but we put the IVC filter there. We knew that one, if he's going to have the treatment, he's going to have profound cytopenia. That's all what we have done. But yeah, we did the right thing, I think.
Amazing. And the lots of, Natalie, you patiently waiting, NHSBT expert, the multiple cryoprecipitate and fresh frozen plasma obtained by BIHS. Do you want to ask where did they get it from and how they processed it and separated
I'm quite
it?
interested in that. Yeah, definitely, because I found both cases really fascinating because I did a long stint in coagulation as well as a senior in the laboratory, but also I know how much it takes with working at the National Blood Service, and we're really so fortunate to have the donors available, where we get not only random but also single dose as well with platelets. So cryoprecipitate is a fascinating product where for DIC, I think it gets overlooked quite a lot here in the Western countries, and they will just keep putting FFP. But as soon as cryo is used, they see such a difference in the fibrinogen, and those symptoms alleviate. So I was just wondering where you did get those the donors from, especially for the platelets.
Yes. So in our hospital, actually, blood bank facility, blood bank collected blood from the voluntary donor, but there is no central blood collection facility in our country still now. So we voluntarily collected whole blood, and required product we delivered, and the other product we try to preserve. So blood collection consultant, Dr. Sabrina also present. She actually did this activity nicely, and we used FFP because at that time cryoprecipitate was not available. That is, it took 24 hours for our hospital. So we use this patient also suffering from hypotension as well as DIC feature. So FFP was not our target component. Cryo was our target component, but considering all scenario, we had to use FFP. So now platelet concentrate also same. We give the RCC and we try to preserve the platelet concentrate as a byproduct and try to use it for another patient actually. So we are developing facility like this way.
That's just fascinating because there's such a lot of work in the donor side of blood transfusion. So I really appreciate that. That's a lot of work on your part, as well as treating the patient as well. Amazing.
Yeah, amazing. We are so grateful to our BARTS and the Royal London team who actually visited many times to the tertiary centers with the Red Crescent in Bangladesh. And since 2012, we are able to now get the cryoprecipitate for various reasons, like the case you have seen, and also for the hemophiliac bleed, because factory is very costly, as you know, and they get the cryoprecipitate, which is available and affordable in the country. And Professor Passi and the Danhart has done lots of work in Bangladesh. Now, we have Tasmim, Professor Dipta from the BARDEM. Do you have any comment as an expert panelist and the clinical hematology and transfusion head in BARDEM General Hospital? Tasmim Farhana Dipta. Professor Dipta.
Dipta connected, but she is sick now today actually, so mentioned it earlier.
We have the histopathology Professor Brigadier General Jainul Islam, I think he has kindly accepted our invite as an expert panel. Sir, any comment from your side? Professor Jainul Islam, Brigadier General Jainul Islam.
Thank you, sir. But I have seen both the cases, though I am not that much acquainted with hematological diseases. Definitely, what I have observed is both the cases were managed nicely, and huge diagnostic support still we are lacking in our countries. That is the widespread FISH facility as well as GS facility. Those are not available. But morphologically, we usually try to designate these cases by using some immunohistochemical method like on refined biopsies. So and after that, usually our samples those are sent to our neighboring countries for further finalization. So definitely we need to develop those parts, and I must congratulate Dr. Rumi and Dr. Kamrujaman for their very nice cases, very nice presentation, and both were are well managed, and I must congratulate both of them. I've got one query, sir, regarding this APML. And in second cases, that case was CD34 positive. I think in APML, usually it remains negative. Can it be explained, sir?
Yeah, some of these cell we do see, as some of the speaker highlighted, that some percentage CD34 can still be positive. As you know, about 5% myeloid cell within the marrow can be CD34 positive. But you are absolutely right; it usually negative, but the positive with a weak dim positivity is not uncommon as well. Is the important thing about an acute promyelocytic leukemia is the promyelocyte cells. And when we see in the right clinical context, we actually jump on to start ATRA if the count is less than 10. But if the count is high, we try to reduce and start ATRA while we're waiting for the PML, RARA, FISH cytogenetics, because we cannot afford to wait. But we now have the flow cytometry access in Dhaka. And if an individual send a sample and said CD34 positive, could it be APML or non-APML? I think that will be not the appropriate things. Starting ATRA is important. CD34 can still be weakly positive in some cells as well. Yeah, we do see it. Yeah. Thank you.
Sir,
Thank you.
Sir, Dr. Ashikujaman, can I ask you one question, sir?
Yeah, please. Yeah.
CD34 can be positive because myeloid stem cell is sometimes in APML is affected. I work as consultant flow cytometry in LabAid for last 3 years. So HLA-DR is never positive in APML because antigen presenting cells are present HLA-DR. In these cases, HLA-DR is also positive. So, and there is no RARA mutation, PML RARA, PLZF RARA, NUMA RARA, STAT5B RARA. Qualitative karyotype reveals no translocation, and FISH didn't see any translocation. And we have 10 to 15 case reports. In NHS also ASH some reports that AML can go to remission, partial remission, which is in this case after giving ATRA. So can it be a AML case? So because all the evidence go for AML without morphology, but morphology is a very substantial. It cannot be our core dependent part. So my suggestion maybe we should treat is at AML. You can consider with DA3+7 followed by high-dose chemotherapy, because it is a young patient. It gives him a very high curative potential. Thank you.
Absolutely. It's a very good comment, you see, and we touched the basis on that. Because of the PML, RARA, some percentage of cell and the ATRA and ATU now responded very well. So Marian will have a look at the case again, I think, in details, and then advise us about the possibilities of APML or non-APML. cases. So that's the first case you talking. But second case, there is no question about it, is APML. He responded very well, and all the features PML RARA was muted, the positive as well. So that's well taken. Yes, absolutely. Absolutely. As I said, I think the 4,000 years ago, arsenic dioxide was the treatment in China for AML, and they believe 10% patient has been cured with toxicity. Now we have smarter molecules here, arsenic trioxide, as you know, less toxic. When you say arsenic to the human non-doctors, they will be very panic and scared about it. We always have a non-hematologist, non-medical individual join in as an expert, and which is really, really good to have some people who hasn't got any expertise in medicine. Justice Imanali, if you have any comment on the two cases you heard as a non-expert, non-hematologist, your observation, sir. Justice Imanali, Senior Most Justice from Supreme Court of Bangladesh.
Thank you very much for giving me this opportunity. I'm very impressed by the work done by Dr. Rumi. It seems that it's a very successful case, and I'm happy to see that. And I'm also very happy to see the collaboration between the experts in Bangladesh and the experts here in the UK. Because that, in my mind, is the root, the seed which has to be sown, and we can get greater benefits from now on forever. With the aid of technology, we can now use all the facilities available in the Western world as well in Bangladesh, in a poor country like Bangladesh. Yes, I'm very happy to see that the very highly effective technological machinery is being used in Bangladesh. Of course, there are very few. Perhaps the doctors here in England could facilitate further supply of technological machines so that they can be utilized in Bangladesh. But as you can see, the use of the machinery, the use of the technological development has aided the recovery of the patients. And I'm happy to see that. I'm very happy to see the collaboration between the two countries. I'm not a doctor. I hear all these medical terms. It goes over my head. But I see the result. And the result is fantastic. Thank you very much.
Thank you. Thank you. With all this, I think I will request Professor Fazlur Rahman sir to conclude the session from Bangladesh Institute of Health Science, BIHS in Mirpur, Dhaka.
Thank you so much. I'm not, much to say. Again, we are back after a gap of about 2 or 3 months, 2 months. But it's a very focused comeback. We congratulate all the international faculties, and mostly I thank our two presenters today and other experts of Bangladesh. As Dr. Brigadier Janul was saying that, yes, we are having tissue pathologists, but in the hematological side, still we are lacking most of the investigation facilities. But and we're a long way to go. But in BIHS, we're a very low resource organization, but we're trying our best to come up and to add more and more facilities in the days to come. And we hope that this BIHS, BADEM, and BIHS, these leading healthcare giving facility organizations in this country, and collectively, if we try, we will overcome these deficiencies and gaps, and we'll be able to help our people to their utmost facilities. And with this, I congratulate and all the presenters, facilitators, our experts from home and abroad for joining this session. And we hope that we'll continue this type of sessions in the days to come. Thank you, everybody. Thank you.
One more thing, sir, your initiative in BIHS and development of the hematology services and the outcome will be presented to the British Society of Hematology conference in Liverpool on 30th of April, which is next week, Tuesday. So thank you.
Thank you so much. Thank you so much.
Thank you.
Yeah. Thank you, Dr. Amin. Thank you.
Thank you.
Okay.
Thank you.
So
Thank you.
here we close this session. Thank you.
Thank you, sir. Thank you all. Fascinating. Brilliant.
Thank you. Oh.